Thank you very much, and thank you for giving me a chance to speak. And that was a very, very elaborate discussion on ERAS by Azam. Thank you for making it easier for the rest of us. We don't have to actually present anything, but we'll go through our slides. And before I start, I'll just comment that there is some disclaimer. I was helped in making this presentation by Priya, Maria, and Soha. So this presentation belongs to them also, and I would like to acknowledge our anesthetist, Akbar Mistry, sitting here, who's taking the forefront of this project in SIUT, and Tahira is the person who provided all the actual data. So I have no idea of the data. It is provided to me. So let's start. We all know the definition of ERAS by now. And the first experience in pediatric general surgery, this is probably the most comprehensive protocol for pediatric cardiac surgery and ERAS associated with it. And they found that they are going to do a randomized trial, and this is in 2023, published in 2023 as a proposal. So we are going to wait for the results to come out hopefully soon. And they looked at the preoperative data, which we already know are 3, and they looked at sedation and blood conservation and perioperative nausea vomiting management. And in the post-operative variables, they looked at all those that we have already discussed. So initially, like somebody had spoken about, it's 22 variables, but you can cut it down to your requirements and what you can do and what you can't do. So this was the initial study from Boston, and they looked at their current way of doing ERAS, and they found that they had about 54% extubation, which was, they called it fast track, within 8 hours of surgery. They did use a lot of multimodal pain management. Intra-op it was less, post-operators was 100%. And when they compared the pre and the post ERAS period, they found that the ventilation was a little less and the ICU stay was also a little less. Both were about getting to a p-value of significance. But there was no difference in the complications or hospital outcomes. And then they did another study 2 years later, and they looked at the results again, and 18 months of audit with 559 patients, OR extubation improved from 16 to 27%, ventilation reduced from 7.6 to 6 hours, and opioid usage decreased by 20%. That means they were increasing more multimodal method of analgesia. The European survey was really surprising. We all have heard a lot of studies about the European system, but this is about pediatrics, and they looked at 98 centers. Only 3 had of them 50% did not respond or responded incompletely, so those were excluded, and they had about 48 centers in the study, and that 7% had the complete ERAS program and were practicing it. Only 7%. 31% had the intraoperative components of ERAS only. 31% used regional anesthesia, and 26% used local infiltration into the wound as an pain medication. So it doesn't mean that just because they are giving us more articles to read, that they are actually doing it. And this is an eye-opener. Let us come to SIUT, let us come to Pakistan, let us come to Karachi, let's be local. And probably, I'm not sure, but probably we are the only center which is producing data to support what we are doing. So we started off with open heart surgery. Just look at the ASDs. Numbers are small. It's not huge because we have only started about a year and a half ago. But if you look at the pointer कहाँ से आ रहा ऊपर? Can everybody see? ये तो dead हो गया. इसका तो pointer नहीं चल रहा. So if you can see, 92% of our ASDs are extubated on table. 92%. And 3 that needed extubation later on got extubated within 8 hours. तो मुझे 2 चलाने पड़ेंगे. Okay. And if you look at पर ऐसी तो किया हुआ है. नजर आ रहा है किसी को? तो खुद आगे पीछे हो रहा है. This one. उनके ऊपर आ रहा है, इसके ऊपर नहीं आ रहा. ओह बहुत फेंट है. ओह I don't think you can see it. But anyway, so if you look at it, we were able to discharge one patient on day 1 after ASD closure. And we have been able to discharge 55% of our patients on day 2. That is within 48 hours of an ASD closure. And majority of our patients, only a few patients were stayed because one had pleural effusion and the other had a re-intubation because of trolley, and that patient stayed longer. But more than 90% are discharged within 3 days of the operation. And that is because we had 100% MDT meetings preoperatively and 100% surgical timeout intraoperatively. If you look at the VSD, now these are all ages. We had 66 of the 44, we had 66% of patients extubated on table. Even a 3-month-old will be extubated on table. And of the 23, that is 34%, we had about 27% extubated within 6 hours. And their length of stay, again, if they were older kids, they were going home on the second post-operative day, but majority of us, more than 50% were going home within 3 days. That's early discharge. Obviously, we had our own problems. And again, we had the same 100% surgical MDT and surgical checklist. What about tetralogy of fellow? And this includes pulmonary atresia VSD with the Rastelli type of repair. And of the 91 patients, 60% were extubated on table. We had a few re-intubations, and that is where our work is now concentrating as to how to reduce that. And of the 40%, 23% extubated within 6 hours. So that is early extubation. And again, you can see some of the tetralogies we were able to send home on day 2. And majority of them have gone home within day 2, 4 or 5. They also had 100% MDT and intraoperative checklist. So how are we addressing the program at SIUT? We are counseling, but I think that we need better counseling, a more targeted counseling, a more effective counseling. Sometimes we counsel the parents and we think that they understand, and maybe they don't. We have our own sedation protocol of ketamine and or midazolam when we take the patient to OR. We were using our NPO status of 6 hours, but now we are reducing it to 4 hours, and recently we have covered it down to 2 hours of liquids that they can have. Intra-op for blood conservation, we are using transamine, and we do modified ultrafiltration in all patients across the board. And that brings up not just the hemoglobin, but also the hemodynamics stabilize, and the amount of post-inflammatory response decreases. We have concentrated on preventing post-operative nausea and vomiting by implementing a protocol of giving ondansetron and methylpred or dexamethasone intraoperatively as well as post-operatively. Post-operatively, our on-table extubation and early extubation in ASD it's about 100%, in VSD it's about 78%, and in tetralogy of fellow it's about 80%. I don't think this is being done anywhere in Pakistan, and it's very, very comparable to data from other big centers in the world. Early feeding, we start water within 2 hours, and if they progress, then they start having their milk if they are infants, or other diet if they're older. We try and remove our lines as quickly as possible, usually the first post-operative day, unless there is a reason to keep them. So pacing wires, if they remained in silence rhythm throughout, and the chest drains are removed on day 1, along with A line and Foley's. So the only thing left is a CVP line, and if that is because if they need, if they run into a problem. We are trying to implement an early ambulation. We have not been able to do that. The concept of ambulating within 4 hours, I think it's a change in our own thinking, maybe. And but we are working towards it. They all ambulate on the day 1 post-op once the chest drains are removed. If the chest drains are not removed and it's because of effusion, and the effusion is coming from the chest, then we put them on bags and ambulate them. It becomes much more comfortable rather than carrying that heavy underwater seal. So we focus on all our patients, look at before extubation or before removal of drains. We look at SITs, we look at cardiac function, we look at effusions, and we also look at gut motility before starting them on parenteral feeding. And this all leads to early discharge. We have shown that we have been able to change the concept and have been discharging post-operative pediatric patients fairly early. This is isko chala do bhai. This is day 2 post-op patient. Okay, it doesn't matter. अगर नहीं चल सकता, वो चल रहा था. ठीक है, believe me, वो चल रहा था. ये अगर प्ले हो सकता है, वो आगे चले जाएगा ना. प्ले उसका तो वो आ ही नहीं रहा. Anyway, so it's okay. It's okay. So in conclusion, we do need more coordinated efforts to implement the ERAS concept in pediatric cardiac surgery and to harvest the benefits of it. And monthly sharing of quality metrics will allow multidisciplinary collaboration, provider engagement, and opportunities for research and process improvements. And that is the most important thing, is that you have to audit what you are doing. If you do not audit what you are doing, you are just doing without knowing what the results are. And I feel that without sounding or boasting, that we have been able to achieve some elements of ERAS in the pediatric setup. And I'm sure if we all make the effort, we can easily do that in the adult setup also. I'm sure that is being done, but maybe it is not being documented and the data is not being shared. Thank you very much.